The historical perspective here is important. These are procedures to some degree that have been performed in the modern medical era since the 1930s.
Welcome to the Joy Tuck Club, the podcast that celebrates the beauty and diversity of transgender individuals and identities. I'm Rachel, my pronouns are she, her, and with me is my wife and co-host, the beautiful Phoebe.
Thank you, Rachel. Also she, her.
What are we doing today, Phoebes?
We're sharpening our scalpels, girding our... Oh, screw it. I can't do that thing we usually do. Our community is in crisis.
It sure is. And on both sides of the Atlantic.
Yeah.
There was that one-sided Supreme Court ruling here in the UK, and that was followed by the turfy guidance from the EHRC. And it's trying to drive us from public life while putting our safety at risk.
Yeah. And then came that report in the US from the brainworm-led Secretary of Health and Human Services, the worst Kennedy ever. And it's yet another bastard child of the Cass Review. It's seeing a serious effort to ban all gender-affirming care in the US, including HRT.
Little side note, every trans person needs to think about DIY, even if you just have it as a fallback.
Yes, absolutely. Yeah. Start researching.
Anyway, so who are we talking to today?
The President-Elect. Not that president, although this one is of WPATH. Dr. Loren Schechter. He's currently on their board of directors, is the head of gender affirmation surgery at Rush University, and we recorded this interview before the SC ruling or the HHS reports dropped, and its primary focus was bottom surgery, as part of the research for our book. But it does contain questions relevant to the landscape today.
Although Dr. Schechter is quite skilled at responding to thorny questions with a diplomat's care.
Oh, a scalpel, almost. But I guess that's the role, though, isn't it? Everyone's forced into politics through this process they're undergoing, where WPATH itself was dragged in and then greatly maligned these past few years. And it's now targeted as one of the principal scapegoats behind an imaginary crisis.
Yeah, so while we didn't engage as much as we wanted to on some of the big questions facing the community as a whole, we did get a lot of good info. Unlike anyone else we've interviewed so far, he does both male-to-female and female-to-male procedures, and a lot of them.
Yeah, but, the thing is, for background, he's hugely accomplished in his field. He explains why he is able to be so skilled as he is at all these different types of procedures, but it goes beyond that as well, because he's been very involved in research. He's a very published individual, and he's even won an award for his efforts in LGBTQ plus advocacy.
Wow, he has so much going on. I'm surprised, yet very grateful he managed to find the time to talk with us.
Me too. We did have many questions we didn't get to ask.
So many questions.
Yeah.
Anyway, let's take a listen. Cue the harp.
Thank you, Dr. Loren Schechter, for joining us at the Joy Tuck Club.
My pleasure. Thank you for asking me to meet with you today.
You perform 100 to 150 gender-affirming procedures per year. What attracted you to this particular field?
Probably a bit more than that, probably 150 to 200 or so per year. I really was first exposed to, I won't even say the field, because I'm not sure that it's fair to say that there was a field, so to speak, 35 years ago. So I was first exposed to the area of transgender health back in medical school. We had a program, a surgical program. And while I was familiar with the concept and using language of the day, the term would be male to female or female to male, or using the term sex change, had been familiar with that, it was limited. And so I was first exposed in medical school, and then in my surgical residency. We're going back into the 90s at that point. And then when I finished training and moved on and began my professional career as an attending, people asked if I would continue doing the work and caring for people. And I said yes. And I never anticipated. I don't think many people would have anticipated that there would be the number of people we see now seeking surgical interventions. And so, to some degree, I think it was a confluence of events. We have changes, at least in the U.S. at the time. Insurance companies didn't reimburse or didn't cover the care. People typically had to travel. Things in the 2000s began to change in terms of societal and social shifts, the internet, connectivity, changes in insurance coverage, and so I think it was really a confluence of these events, and we began to see and more people interested in surgical interventions.
We've talked to other surgeons, such as the founders of Facial Team and others who tend to favor hyper-specialization. They might just focus on the brow or maxillofacial, etc. But you tend to do quite a lot of different procedures, which puts us in a unique position for this conversation, because we can ask one surgeon in particular, do you have a favorite procedure to perform? Are there some that are more complex?
I used to do face, chest, breast, genitalia, body. I'm now primarily less in terms of facial work, more chest, breast, genitalia, body. Just an evolution. I'm not sure it was intentional, but just how the practice evolved. Part of our training in plastic surgery is and where we're a bit of a unique discipline, is that we're trained to operate all over the body. And so what I think makes plastic surgery unique and sort of in a way almost a surgical home for people is we're not limited by gender, age, body part, and so forth. And so we care for people for a variety of reasons and conditions, gender being one, but of course, maybe cancer reconstruction, birth-related conditions, trauma. And so it's putting those skill sets together and working with a person and helping to develop a plan, that ultimately works for them. And so back when we started, I think the field was a little less specialized. We've written a little bit about, training and education and how that's evolved and some recommendations for that. And I think it reflects, as you've said, some of the sort of subspecialization, so to speak, in the field. In terms of complexity, typically the genital procedure, some of the facial procedures tend to be a bit more surgically complex as compared to some of the chest and breast, perhaps body procedures. All are major surgical procedures. So not wanting to say that we shouldn't take them all quite seriously. That's a personal decision in terms of pay. We see people, as we've talked about, sort of levels of we'll call surgical complexity for a particular procedure. But, for that person, for that individual, any procedure is right. To them is most, although it may be a less technically complex procedure, for them is of course of utmost importance. I think the genital surgeries tend to be the most complex. They're also very rewarding and challenging. For us, it does require a team. And so some of the things that we've worked on and built around the years are recognizing how other disciplines can be helpful. So, for example, over the last several years, we've added a pelvic floor physical therapist to our team. And so for the bottom surgeries, the genital surgeries, that's of course very helpful, especially with some of the aftercare that's needed following vaginoplasty or phalloplasty. As we've seen expansions in the US in terms of insurance coverage, we've added a social worker to the team that helps, again, with we call case management or helping to develop an aftercare plan so that people can recover safely. Many people travel for surgery, and so logistics around travel can also present challenges.
So specifically regarding genital surgery, or as others call it, bottom surgery, what preparations, what techniques do you find provide the best results aesthetically and functionally for both MTF and FTM patients? And what do you recommend in terms of preparation? So, for example, follicle scrapings typically, is sometimes performed. Other times, obviously, it's other types of hair removal prior. What's your approach?
And so again, we offer a variety of approaches. And so part of what that meeting is and the consultation is speaking with the person, learning about their goals and expectations, performing an exam. And so different procedures may benefit people, or people may benefit from different procedures. So I wouldn't say there's one necessarily right or wrong procedure. In terms of vaginoplasty procedures, for the most part, most of the external work, meaning the construction of the clitoris and vulva, labia, etc., are similar. Differences tend to be in the choice of the lining. And there are three generic options for that: skin, intestine, and peritoneum. And it depends on each person. When skin is used, one of the considerations, as you've discussed, is hair removal. We do recommend some preoperative hair removal. We are able to remove some during surgery, or it's cleared before, less likely there is to have hair growing internally. Other procedures, peritoneum or intestine, require intra-abdominal surgery. Intestine, of course, some rerouting of the intestine. Each of these procedures may have certain advantages or disadvantages, certain risks and benefits, and those are the discussions that we have with individuals. In terms, for example, of phalloplasty, again, there are different ways or different techniques by which that is done. Some individuals choose to have the urethra lengthened, others do not. There may be different, we call donor sites, parts of the body from which tissue is transferred to construct the phallus. Most common tend to be forearm, thigh, sometimes back, tummy area, and so forth. And so it's working with the patient and examining them and helping, to arrive, we call, using a shared decision-making approach to a procedure that works best for them.
And you mentioned earlier that your team includes, for example, a therapist focused on pelvic floor exercises. But there's also a pattern of depression post-bottom surgery, probably related to the big build-up, and then there's a case of, well, what next? Or, the purpose is satisfied. And so do you work with mental health professionals as well directly, or is it a case of patients going out and ensuring they have that care on their own?
Yeah, so again, it will depend. There are some people who have relationships with people prior to seeing us. There are other times where we will help and make referrals for people to connect with therapists. Part of that preoperative process, though, is ensuring that the person who is helping to provide that support, I don't mean the surgical support, but some of the emotional, social, psychosocial support, that the person who has seen the individual before surgery is available to continue with care after surgery. And, we see in the general practice of plastic surgery, we also see sometimes post-surgical challenges not related to gender surgery. People who may be undergoing certain cosmetic procedures may have a certain almost elated experience and then be a little bit depressed. And so those aren't necessarily uncommon reactions that people have to a range of different surgical procedures and different plastic surgery procedures. But I think it's a good point, and it's a point that we emphasize that we as surgeons don't work in isolation. We don't work in a vacuum. We work as part of a team. Some people won't may need more support after surgery, which isn't necessarily uncommon. And so, I think that's important, especially in today's climate, to recognize that surgery is really, part of a multidisciplinary approach. And in that regard, there are many different surgical procedures performed for many different reasons that also benefit from a multidisciplinary approach.
Right, and obviously this isn't just exclusive to trans patients, it applies in the cis world as well. So
it applies for a whole range of surgical procedures. And, I think, again, some of what we see in the current climate is somehow our area being treated differently or disproportionately as compared to other areas. And so many areas of medicine and surgery benefit from a multidisciplinary approach.
Do you see international patients, or are they just from the States?
Primarily States, but we do see international.
And how about cost? Most of your patients covered by insurance, or do some pay out of pocket?
Yeah, majority now are covered by insurance or government payers from if it's for an international patient. There are self-pay options for individuals who where insurance or a third-party payer doesn't cover. But most these days are covered, which is very different than 20 some years ago.
I want to switch to talking to the future of this type of surgery. You've been very busy. You've written a lot of papers. Do you have a particular topic that points towards a future that, for example, may lead to an FTM having a fully functioning penis? We were having this chat with someone last night about that.
It's been an exciting time, much progress over the last couple of decades, and we always look to the future. I think one area of research interest I have is in the area of uterine transplantation for both cis and trans individuals.
Oh.
We've written on that topic. Of course, in cisgender women, it's been done in a number of, not only in the U.S., but other countries, of course, a number of successful live births resulting from uterine transplants or as a result of uterine transplantation. Topic, which is a large topic to cover, but is part of sort of the field of what we call VCA, vascularized composite allotransplantation.
So you perform surgeries, I believe the figure that we found is 85 to 90% transgender patients, is that right?
Yeah, approximately, yeah. These days, I still do other plastic surgery procedures as well.
Yeah. And with the current efforts to ban gender-affirming care, but only for trans patients, do you see any difference in performing these procedures on cis people compared to trans? And how do you think the government can make a moral argument for banning one and not the other?
Yeah, and so we use similar techniques in many different procedures depending on what the basis or the condition upon which we perform the procedure. So as we talked about, there may be reconstruction for individuals born without a vaginal canal, certain congenital or birth-related conditions, reconstruction following cancer or tumor, reconstruction following infection, reconstruction for transgender individuals. How this will all play out in the legal arena, of course, I don't know. Phalloplasty for individuals who've experienced traumatic injuries, birth-related conditions, again, so, other conditions. Those are ongoing battles in the courts in the United States. How it ultimately will, or what the ultimate result is, we're not sure.
But both procedures on trans and cis people are classified as gender affirming, or wouldn't you call them both that?
I think people certainly refer to may refer to procedures as gender affirming. Some people may consider breast reconstruction, for example, and a cisgender woman as gender affirming. But I think the distinction is the basis upon which we perform the procedure. So some for the ICD, the International Classification of Diseases, term gender incongruence, gender dysphoria, and so these are procedures, I would say, that uh, whether performed for cisgender individuals or for transgender individuals, have a wide range of benefits. Some may be improved quality of life, self-esteem, relief of dysphoria, et cetera. And so it's the condition, I would say, upon which we're performing the particular procedure. We may use similar procedures for a wide range of condition, standard surgical procedures, skin grafts, flaps, et cetera.
And WPATH's activities include conducting research to gather the evidence to support the evidence-based standards of care, but also advocacy. So what role do you think WPATH can play, or how can it evolve to help push back against the current political winds?
Yeah, so WPATH is an international and professional organization. Advocacy is common certainly in the United States, in professional medical organizations, and many, perhaps even most, professional organizations, medical organizations in the United States engage in some form of advocacy. I think, our goals of WPATH, helping individuals achieve lasting personal comfort. We do that through the best available evidence, and part of that is the role with the standards of care. Standards of care referring to clinical guidelines, first published in 1979. And I think the historical perspective here is important. These are procedures to some degree that have been performed in the modern medical era since the 1930s. In terms of professional groups, WPATH until 2007 was referred to as the Harry Benjamin International Gender Dysphoria Association. And its roots, though, predate that. They really go back to even the late 1960s, early 1970s, some of the early meetings occurring in the United Kingdom. And so professionals have gotten together and in a way to discuss and advance healthcare for transgender individuals and gender diverse individuals, really for probably more than 50 years or so. And so these aren't new, these aren't novel. And we continue to use the best available evidence to help make recommendations as to how to guide care.
And do those recommendations support the need for some trans people to source and manage their own HRT? Because I know in the UK and in the States, like that's trying to get stamped out. So what's WPATH's opinion, and yours as well, on DIY HRT?
So, I do not prescribe hormones. So, it's typically, not something upon which that are topics upon which I would opine. I would say, though, that people should, and part of the goals of WPATH and the standards of care, are to help people achieve access to safe medical care. And so I would recommend that individuals work with and seek professional medical consultation when they're considering or using seeking medical interventions.
Just while we're touching on hormones, do your patients have to stop HRT before their procedures?
So it depends on the procedure. For vaginoplasty, our current recommendation is for individuals to hold their hormones for 2 weeks before surgery. They resume them about a week after surgery when they're up and walking. We typically don't discontinue spironolactone if people are on both some form of estrogen, progesterone, or estrogen and spironolactone preparation.
Okay, so we're aware we're running out of time. We have just 2 questions left. And thank you so much for what you've been able to give us. This one is a little tricky. Would you comply with an order to turn your records over on interstate patients to a hostile interstate AG who you know is potentially tracking and maybe going to prosecute those patients?
I think, these are difficult questions. And in this time, my um, obligation is to our patient. I work within the context of an institution. And so, I have a benefit of having, institutional help regarding answering some of these questions. But, what I think is really a chilling effect and frustrating is when people talk about we need more evidence, we want more evidence, yet create an environment in which people are concerned and understandably reluctant to participate in a research study for some of the reasons you've just elucidated. And so asking people or even forcing people to participate in a research study in order to access, this care has ethical considerations. And then understandably, people who are afraid of information being turned over for legal reasons are also reluctant. These are things we've heard from our patients. The specifics of a situation would depend on the specifics, and we would work with our institution in doing that. But going back 20 some years, even before the insurance companies covered it, you're probably well aware, right? People were concerned regarding information or how it might impact their ability to get health insurance, perhaps nothing related to trans health, just general health insurance, disability insurance, life insurance, employment, and so I'm certainly hoping that we don't re-enter that era.
Right. Finally, what advice can you give to transgender people now who have little hope for the future of gender-affirming care or for their much-needed access to it in the United States?
Yeah, it is it's a difficult time in the field. It's a difficult time for people, our patients, professionals, having, perhaps a little bit, 25, 30-year horizon on which, to look. I think we're still in a better position in terms of access to care than we were a few decades ago. I think there are now more support systems in place. There are people who are out there really supporting access to care and sticking up for individuals who benefit from care and supporting access and safe care in this area. And so I know it's challenging. I hope people. There are many avenues for people who need help and need extra support. Many people we care for are expressing those concerns, as well as our staff. And so keeping hope is important, knowing that people are there supporting and continuing to do the work and continuing to really follow the best available evidence to help people.
Well, okay. Thank you. We're going to help pass this on. Nice message. And thank you for joining us here at the Joy Talk Club.
Well, it's my pleasure. I appreciate the opportunity.
Thank you. Wow, that was a short but informative interview.
Yeah, it was.
Yeah, did you enjoy that?
I did.
What did you take from it?
Well, let's go back to the beginning of gender-affirming care, and knowing that this field barely existed not so long ago. I mean, there were initial surgeries going back 100 years, but in its broader aspect, it wasn't so much a field as one-offs, even just 35 years ago.
Yeah, you're talking 35 years ago. TERFs and GCs would have you believe that being trans is a relatively recent thing.
Oh, yeah, that's right.
Yeah.
Social contagion brought on the air.
Certainly only since like the 2010s.
Yeah. But also, something to keep in mind is even with all that's going on, it is, as a whole, better than it was. even just a couple or a few decades ago.
Currently.
Yeah, currently.
Just for now.
Yeah.
I can see it getting worse. Yeah, if things carry on the trajectory they're on, I think we're going to go back to those dark days.
The range of care wasn't available.
Yeah.
It was probably harder. I don't think GICs in the UK existed, for example.
No.
Informed consent wasn't really a thing, but I think it operated anyway because there wasn't... What didn't exist was all the gatekeeping.
Yeah. I think things are definitely going to get worse. Say in the States, I think access to healthcare is going to go. They're going to take away the insurance aspect. The UK, I can see them going the same way with respect to hormones.
Yeah.
It's all looking pretty grim at the moment.
Yeah.
Currently, it's not so bad.
Again, research DIY if you haven't.
Research the DIY.
At least with hormones, your brain can operate the right way.
Well, they're going after surgeries as well, aren't they? There was an article we read the other day in the Tory Graph stating how much taxpayers' money is wasted on gender-affirming care, with men having their penises removed.
No, they not only misdescribed it, they also didn't mention any comparative costs. For example, that there's about 300 times as much spent on
Viagra. And probably plenty of guys in the UK with brewer's droop.
Yeah, but I don't want any of my tax dollars going to that gender nonsense.
Yeah, speaking of operations, the one thing I was very interested to learn more about is the uterine transplants that Dr. Schechter was talking about.
Right, let's throw some fuel on the fire.
Yeah.
I mean, honestly, if I wasn't the age I am, I would be... If I was in my 20s or 30s, then I'd be like, yes.
Yeah,
I want this to happen.
Yeah.
I've felt that ache inside. But there's been 120 performed worldwide. There's been, like 60 live births. He didn't mention that. That's the number we looked at.
Yep. The TERFs will ask you, is it ethical?
Yeah, but is cutting off all our care ethical? No, they don't give a shit about ethics in the same way they don't give a crap about actually protecting women or children.
Right. Okay. So we don't care what they think.
No. There's a lot more work to be done vascularly with blood supply and so on.
So let's just state this is currently only in cis women.
Yeah.
But we keep our fingers crossed that it moves over to trans women as well.
Yeah, absolutely.
And the TERFs will absolutely have a field day with it because they all lost their shit over some trans woman breastfeeding a baby.
Right.
Imagine a trans woman actually having a baby.
Yeah.
Oh, my God.
Yeah. The thing about all these surgeries is, this is a quote from the doctor.
Mm-hmm.
These aren't new, these aren't novel, and we continue to use the best available evidence to help make recommendations as to how to guide care.
Guides, not gatekeepers.
Yes, that's right.
Is the
Yes.
the underlying message there, I think.
That's the message there should always be. So that's it for this episode of the Joy Tuck Club.
It really is.
Yeah.
That's the end.
No, it's not, because we've got a really interesting interview coming up next week with the amazing surgeon, Dr. Marcy Bowers.
Oh, I loved that interview. It's great. The Marcy Bowers, whose least interesting characteristic is that she also happens to be the immediate past president of WPATH. And she's also trans.
Right?
I know.
It's a big interview too. This is going to be our first two-parter.
Wow.
Yeah. So, thank you, listeners, for tuning in and being part of our community. If you want to connect with us further, visit our website at redandfreckles.com, where you can keep up to date on all things red and some of the things freckly.
Yeah, you can also follow us on Blue Sky, Threads, Instagram and Facebook, but not Twitter. We use the handle @2damptrans on all of our platforms, so you can DM us if you have any questions or topics you'd like us to discuss.
And don't forget to subscribe and rate us on Spotify, Apple, YouTube, or wherever you listen to podcasts. We really appreciate it.
Absolutely, we do. We need the listeners. and the reviews. Don't forget to leave a review.
We appreciate your feedback and support.
So until next time, remember you are valid.
You are beautiful.
And you are transcending boundaries. Boom, 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 boom.